So for femur, AP proximal, AP distal, and then the frog, you're gonna frog the leg outward and do a proximal lateral and a distal lateral, okay? I'll show you guys how to get those two pictures because it's not really exact centering points for the femur. We center and make sure we're on the bone in the middle of the thigh. But as far as the light field, our top of our light field goes to level of the ACES for the proximal pictures. And then for the distal pictures, we wanna make sure we have 2 inches below the knee. So on some people, that's going to mean that our second picture is open quite a bit. And for others that are shorter, that means that our second picture is going to be collimated quite a bit because we only need to have a little tiny bit of overlap with that bone, okay? On the hip, we have an AP and a lateral, so AP and frog leg, pelvis, AP and the bilateral frog leg, an inlet outlet, and then the Judays. So for practicum, when you pick, you're going to pick either femur, hip, regular pelvis, inlet outlet pelvis, or Jude pelvis, okay? So everything's going to be graded on a 2-picture scale, okay? So I need a patient, please. Somebody, anybody? Everybody? Thanks, Isaiah. All right, so have you lay down with your head on the pillow for me? You can leave them on. So for this practicum, everything will be on a 14 by 17 except for the hip. The hip will be 10 by 12, okay? So we're going to use the table bucky for all of these. That means we're going to bring our table up to the blue light and then our tube down to the silver 40 inch, right? That's how we know we're 40 inches to the bucky. This direction. We have to make sure that we're in detent, right? So as far as back and forth. Okay. And then we will start with femur. So for femur, I'm gonna put my image receptor in lengthwise, okay? So it's gonna go all the way in. Push that there. And then I'm gonna go ahead and line up because I'm as far this way with my IR as I can be. Oh. Also, whenever you're lining up, make sure that this is straight so that you're actually lining up with that image receptor, okay? I'm gonna open to be 17 top to bottom, 14 side to side. And I'm gonna show you guys here on his right, okay? So I'm gonna poke around on the hip and we're gonna find the ACES. The ACES is that bony bump on the front of the pelvis, okay? So that's right here, and that's where the top of my light field is going to go. So, right about there, I can collimate in side to side, okay? And then I'm gonna get a marker. And for femur, we're going to put our marker in the bottom corner, okay, for the proximal picture. Because when we go to do our distal picture, we're going to use that marker to prove that we have overlap, okay? So I'm gonna have you go ahead and pigeon toe your feet. So we pigeon toe for the proximal AP femur so that we get that femoral neck nice and parallel with the image receptor. Okay, so this is my proximal AP femur. Top of my light field is here at the ACES, and then however far down I can get is great. Shielding. We're going to use the lap shield over our patient's chest and abdomen for these ones. So just like that, but then make sure it's not in the light field so you can kind of roll it up, okay? So that's my AP proximal. I'm not gonna move my marker. I'm gonna have my patient turn his legs so his toes are straight up now. And then we need 2 inches below the knee. So I'm gonna find the bottom of his patella. And then I was not centered good on my table. So I'm gonna have to actually move everything and then line back up, okay? So right about there. And line this up. All right, now, do you see how much extra light field I have? So where my marker is our overlap, and I've got a solid 2 inches above that marker that is too much. Okay, so what I'm going to have to do is go further distal so that I can now collimate top to bottom a little bit so that I still have my 2 inches below the knee, but I have my marker re-exposed on the distal. Does that make sense? So I have to reline back up. So the whole point here, again, is not that we're centering at the knee or that we're centering above the knee, below the knee, whatever. It's making sure that we have overlap with our marker proving that, and then 2 inches below the knee for that distal picture, okay? So everyone's collimation top to bottom is gonna be different for that image. If somebody's 6'4", you're probably going to have it open 17 by 17. If you have someone who's 5 foot tall, you're going to collimate it down quite a bit, and it could be that your distal is just this teeny tiny image, okay? So that's my AP proximal and my AP distal. Now for the lateral, I'm gonna have my patient go ahead and bend his leg halfway up, and then go ahead and let it fall outward for me. Kind of scoot your butt a little bit to the left for me. Good. So, and we wanna kind of turn your hips so that this leg is flat to the table. There you go, good. All right. So I'm gonna open this back up to 17. I'm gonna poke on you and find your ACES again. Again, top of my light field at the ACES. And now we're going to turn our collimator head to match the anatomy, okay? So, there. Here am I. Okay. And then, can you straighten this leg a little bit, actually? Good. I'm gonna put my marker down in this bottom corner. So it's the same thing again, okay? So top of my light field is here at the ACES, and I'm centered on the middle of his leg so that I'm on the bone. I have my right marker here in this bottom corner. That's my proximal lateral. Does that make sense? Now, all I'm gonna do for the distal, I'm not gonna move my marker. I'm just going to move my patient. And then I may have to, so with him, I'm gonna have to scoot his leg back a little bit more. Right about there. I moved my marker back into the light, but I kept it in that line. Does that make sense? And then I'm gonna keep coming down. And we can collimate top to bottom again. And now we have overlap. We still have our marker here. And I'm seeing below the knee again, okay? So that is my distal lateral femur. All right, so we have overlap proved by the marker. Here's his knee here. We're seeing light field below that, and that is the distal lateral femur, okay? Does that make sense? So on the femur, you're still only gonna be graded as 2 pictures, an AP and a lateral, but you're going to have to take 4 pictures to get there, okay? All right, so you can relax that leg, go ahead and straighten it out. I'm going to go ahead and change to a 10 by 12 to do the hip, just because we're gonna kind of go in order here. So for the hip, again, we have an AP and we have a lateral, a frog leg or a unilateral modified cleave method, whichever you want to call it. So this one is going to be in lengthwise because we're looking at the length of the hip still, okay? So 10 side to side, 12 top to bottom. And my centering for this, you find your ACES. Don't smash your fingers. Find your ACES, you're going to go 1 to 2 inches in, okay? And then 3 to 4 inches down from there. So again, find the ACES, 1 to 2 inches in. So we're gonna go 1.5. And then from the ACES, 3 to 4 down. So you know that that's 2. That gives us 3 right there. Essentially, it's where the crease of the leg is where that femoral neck is. And so we're centering on the femoral neck, okay? So 1 to 2 in, 3 to 4 down. The other thing that they say you can do is draw a line between the ACES and the pubic symphysis. So if we were gonna do that, I would have him turn his leg in and out. Rotate your leg in and out. Keep going. That's his greater trochanter right here. We know that's in line with pubic symphysis. You can take from the pubic symphysis and the ACES and draw a line and come about 1 inch distal to that. I find that more difficult. I think the easiest is to find the ACES, go 1 to 2 in, 3 to 4 down, and you're there, okay? With that, we have our patient pigeon toe the feet. Pigeon toe the feet. And then bring the heels out just a little bit more. Good, that gets our femoral neck parallel with the image receptor. Our marker for this one is just going to go on the IR in the bucky, okay? So in that bottom right corner or this top right corner is fine. If you are doing your patient's left side, their head needs to go on that side of the table if you're gonna mark in the bucky. Otherwise, you can stick it on the table kind of under the anatomy, but then we're afraid it won't end up in the picture, okay? If you have it on your IR and your light field is open to the size of the IR, there's no doubt that it's going to end up on that image receptor, okay? So that is our AP hip. Frog-legged, pigeon-toed, 1 to 2 in, 3 to 4 down from the ACEs, all right? And then for the frog leg, he's going to bend the right knee and then let your leg fall out where the bottom of your foot is against your calf. There you go. And your centering is the same. You do have to do some adjustment here though, because the leg kind of comes outward. So I find that ACEs again, 1 to 2 in, 3 to 4 down, right about there. And then we can turn this to match the anatomy. Okay, so his ACEs, 1 to 2 in, and then 3 to 4 down. Okay, so I know that I'm still aligned to my bucky because I didn't move my tube or the tray. Okay, so that is the frog leg lateral, turning that to match the leg here. And now we're seeing the greater and lesser trochanter laying on top of each other in a lateral position. All right, you can relax that leg. Questions about femur or hip? Okay. Back to a 14 by 17. Now we're going to go 14 by 17 crosswise in the table because our pelvis is wide, not long, right? So 14 by 17. I'm gonna go ahead and put my marker in that bottom corner again where it's gonna live for the pelvis pictures, okay? Now I do say that we mark on the outside because if we mark that inside, the odds that that marker gets lost in the middle of the bucky and the table is pretty high. So only mark on the outside. 17 side to side, 14 top to bottom. Now for pelvis, regular AP, you need to make sure that your patient is straight on the table, first of all. So actually, yeah, bring your top half a little more to the right. There you go, good. So making sure he's nice and straight there. And then centering for an AP pelvis, you find the ACEs, you go to the midline, and then you go 2 inches below the ACEs. So, again, ACEs is there, 2 inches below, and then at the midline, okay? Make sure your shield is not in the picture. And then pigeon toe the feet, both of them. Now, if you are not confident that you're centered well here, the other thing you can do is make sure you have light field above the crest. So you can poke on your patient's side, find their crest, which his crest is right here. And the textbook also says you can be 1 inch above the crest. So, kind of those are your 2 centering things. We want to make sure we don't clip the crest, so make sure you have light field above the crest. And then again, find that ACEs, I lost it now, and 2 inches below the ACEs. So really we're right about there, okay? Again, no shield in the light. Oh, and for all of these, our patient is holding their breath for everything for this practicum. Okay, that just means that we have no abdominal movement and stuff like that from breathing. So the pigeon toed gets the femoral next parallel with the image receptor, 2 inches below the ACEs. We're good there. I am almost lined up. There we go. Lined up to my image receptor. And then for the frog leg, bend both the legs out, let the legs fall out, and put the bottom of the feet together. It says to bring the legs out about 45 degrees, okay? And then now our centering is 3 inches below the ACEs. So if you look right there, I'm on his ACEs, that's 2 inches. It naturally puts you in that 3 inches below the ACEs for when we bring the legs up and out. So you really shouldn't have to change anything other than giving your patient the direction to frog the legs, okay? And then with this one, if we clip the crest, it's okay because we got them in our AP image, all right? So AP frog leg, that's it. And then inlet outlet. For the inlet, we have how much of an angle?
40.
Toward the feet. 40 caudad, 40 toward the toes. Okay. Now, we know when we angle like this, it increases our SID dramatically, right? So, what I want you guys to do as far as SID is concerned with this one is we're going to bring this down until we're between 37 and 40, okay? Because if we leave it at this 40-inch on the silver, like we know to do, when I bring this down to the crosshair on the table, I'm at 40, what does it say, 46 inches, which is quite a difference, okay? So, I'm gonna bring this lower. Now remember, when I bring it lower, my light field moves, right? So then we're going to do this again. See where we're at. 38. I'll take 38 because we know I have about a 3-inch gap from my tabletop to my bucky, right? So between that 37 to 40-inch range is good. I'm at a 40-degree angle. I'm gonna make sure I'm lined up. That's gonna be the super duper important thing here with the inlet outlet, is making sure that you're lined up, okay? So we're good there. Lined up. And then, no, we're not. Remember, you wanna line up with your notch on your detector. And then our centering for this is midway between the ACES. So the ACES is important, right? We gotta know where those ACES are. So find that ACES again, and then come to the midline between. And I want you to note something here. Do you see how our line, our centering line kind of curves because of our angulation? We don't want this outer portion of that line in line with the ACES. We want the center crosshair between the two ACES. Does that make sense? So here it's going to look like you're a little bit distal or below that ACES, but if we look at that center crosshair, I'm between the two. Does that make sense? Mm-hmm. So again, I gotta bring this up more. The shield's gonna be kind of a pain for these ones. If you get inlet outlet, I suggest you fold the shield in half and put it over the patient's just kind of upper chest area, okay? So between the ACES, feet don't matter because we're not looking at the femoral head and necks here, we're looking at the pelvis itself, okay? So 40 degrees, line everything up, get your SID to about 37, 38, 39, and then center midway between the ACES. That's an inlet. Outlet, we have the range for our angulations. So for males, it's 20 to 35 degrees, thank you. And our females are 30 to 45. So 30 falls in the middle of both of those. We kind of can use 30 as the standard for outlet. If you have a patient and you know, like maybe they've had prior imaging and you're able to see that they have a really shallow pelvis, so they need more angulation, then you can start with more, but 30 is a good place to start. Because what we're doing here is we're angling our tube in order to get the obturator foramen to be parallel with the image receptor. That's the point, is we're angling to go straight through those because they naturally live kind of tipped forward in the pelvis. Males, it's less of a tip because of their form of their pelvis. Females, it's more of a tip, which is why we have to use more angulation for a female. Okay. Do the same thing. Your SID should have stayed pretty much the same when we go from one to the other. Oops. How did I push the button? Okay, so right about there. Ooh. 36, I'm gonna go up a little bit more. And now it's too much. It's like little baby movements. You gotta chase your central ray when you move it, right? And then you have to line up again for the outlet. Coming back this direction. And then for this one, we're centering 2 inches below the superior border of the pubic symphysis, okay? So again, having him turn that leg in and out, find that greater trochanter, and you can feel the bony bump, you can stop. We know that that's gonna be in line with pubic symphysis, and then we go 2 inches below that. So right about there, it's typically at about the crotch where the legs meet, okay? And then everything else stays the same. Again, we don't care about the feet for this one either. So outlet 30 degrees, 2 inches below the greater trochanter or the superior border of the pubic symphysis, and that is our outlet, okay? Questions about that? So inlet, outlet are probably the hardest ones for this just because you have the tube angulations. Remember for practicum, your SID is only worth 1 point, okay? So as long as you have your angles correct and you're centered right, try your best to get your SID where it needs to be, but if you're off on that, it's only 1 point, okay? So don't freak out about it. So then the last thing we are going to do, we now can go back to using our normal 40-inch and lining up. Maybe, where is it at? These are the Jude views. So for our Judes, we are going to do bilateral Judes. That means we're leaving it open the width of the pelvis so that we're seeing both sides of the pelvis in each picture. Okay, so it's 45 degrees of angulation. We'll use this sponge. What I like to do is I tell my patient to roll halfway that way for me, put this sponge behind them, roll a little more, and then go ahead and roll back. I like to have them hold the sponge with this arm because most of the time in the hospitals, those are gonna be slippery and they're gonna slide out from under the patient. So you put their arm back there to hold it in place. And then go ahead and just have the patient straighten their legs and keep everything straight. Find the ACEs. We're centering 2 inches below the ACEs, but more to the midline. So, lean you toward me. And if you will kind of find that ACEs and just make sure you have a little bit of light outside of it, you'll be fine, okay? So, center 2 inches below it. Have just a little bit of light coming onto this lateral side of it, and I'm centered at about the midline, okay? If you have a larger patient, this light field is going to look smaller and it's going to look like it's doing less work. But remember, beam divergence, it will hit all of your image receptor, okay? So then after I take this first picture, I tell my patient, remember how much you were rolled up on this side, take the sponge out, and then I want you to roll the other way. Your whole body, more. Okay, roll back. Does that feel about the same? Okay, put your arm back here to hold that. The other thing to note when you are doing this is to put the sponge under the entire core of the body. I didn't say that the first time, but did you see how I have the sponge all the way up, like under his shoulder, all the way down? Okay, so then same thing, I'm gonna poke on this side and find the ACEs. 2 inches below it, centering at about the midline. Okay, and then we're nice and straight there. And that is the Jude views. So it's 45 degrees to right now he's in an RPO position, the other way it's an LPO. And now in this position, we're seeing the left wing stacked and the right wing opened up, and then the obturator foramen stacked and opened up, okay? So those are the Jude views. Does anyone have questions about these? Okay. I will say for this practicum, you have to palpate your patients, okay? Now, it is important to note when you're palpating, let me take that sponge out for you. We don't want to be using like caressing touch or like soft touch, especially because we're palpating on people's pelvises and things of that nature. You're going to a more sensitive areas that can make people feel uncomfortable. So you want to use not one finger, because if you're using one finger, that's poking and that hurts, but you're going to use like 3 fingers and you're going to press with firm pressure, especially when you're poking around for those ACEs. I mean, was I hurting you? But it was like I had a goal in mind. It was not like a petting fashion, okay? Well, I've seen people do that where they're like afraid to hurt their patient, but then you either never find what you're looking for or you make your patient uncomfortable. So just letting them know, okay, I'm gonna feel around for a bony bump and using that firm pressure, okay? Another trick for crusts is using both your hands and kind of getting over your patient and feeling for both of the crust is helpful, especially on a larger patient. Sometimes it can be hard to get all the way in there, so use both hands and push for both sides. Another thing, if your patient's ticklish, they will like tense up, and if you tense your ab muscles and try to poke for the top of your crust, can you feel it? Not very well. So you have to kind of use both hands to feel for them, okay?